just very typical start of my Monday after what I have to admit has probably been one of the hardest weekends I've had in a really long time. So, not that you need to know that, but you're going to notice it because my energy is very different today. We had a really exciting presentation a month ago. We spent a lot of time talking about working with hypo-aroused parts with IFS, which is, I got to admit, that's new to me. I've always been trained to shift our clients into a different state. I come from an ego state background and work in ego state advanced trainings and internal family systems. It's relatively new to me. And so working with a dissociative part, that was fascinating. So I really spent a lot of time on that chapter last month, and I've been spending a lot of time utilizing it in my with my clients. It's one of the reasons why I keep a pretty intense caseload, is so I can practice what I teach. So anyway, so here we are with substance use, which is interesting. You would think this would be the chapter that I could blow through, which is fantastic because I'm a substance abuse therapist, and yet that's not the case, because once again, utilizing internal family systems, really just getting into the depths of it with Dr. Frank Anderson. A lot of it's over my head, so which is good. I like to be challenged, and if I'm going to be working with this population, I should be on the ball as far as all the orientations out there. So let's move in, and I like just starting with this. The opposite of addiction is not sobriety, it's connection. I do a lot of, I work with a lot of 12 steppers. I'm very familiar with the rooms. And, we always say that addiction is in isolation and that recovery is in community. And so it's interesting because, yes, an external community is extremely important, having a fellowship when you're working with substance use, but the internal connection is the one that's really kind of blowing me away. So, so let's get going, and we'll see what we can do with this chapter. So substance using parts. So now we're going to be dividing, we're going to take our client, and now we're going to be looking at these parts of the client. And so the substance using parts in clients with relational trauma often are seeking external relief. So when we talk about complex trauma and our clients coming to us from a relational wound of some sort, we talked about that with vulnerability. That the clients are going to be seeking relief. They're going to be looking for protection. They're going to be looking for escape. That's our definition of complex trauma, is the inability to escape, and where there's no safety and love within like a family system. So our clients are going to look for that. Ruth Lanius did some research talking about how, opiates are connected to attachment. So, it starts to make sense when you think of opiates, hypoarousal, dissociative shutdown, opiates being released due to endorphins. And then you're thinking, oh, opiates provide some type of attachment repair. Our clients aren't getting the attachment that they need. And then, you talk to somebody who's used heroin for a long time, and you're saying, what is it? What is it like for you? And they're like, it's a big hug. It's a hug, really. So all of these connections just start to make sense. And then to be able to work with these parts is really powerful. These parts play protective roles and are frequently tied to both past wounds and present day challenges. So once again, that past present connection that we look at, especially with our adaptive information processing model. The goal in internal family systems is not to stop the substance use directly, but to understand the protective intent behind the behavior and address the underlying wounds. What is the reason? What is the root cause? Once again, kind of hearing some of the language that we use as even EMDR therapists when we're looking for that root cause, looking for the first or the worst. Effective healing involves connection with these parts. We want to validate their fears. We want to find alternative solutions through this internal connection. And there's that internal connection, yet again, not coercion. So yes, if we need a client that has to stop, let's say drinking, for example, and they need to stop it now because they are going to be, maybe they have a felony and they might get their driver's license taken away permanently. We've got ways to do that. And coercion might be a good word for it as far as the parts are concerned, because basically you're just shutting a part down. You're just shutting a part down, and that part has no options. The way that I use it with the 12-step rooms is going to be 90 meetings, 90 days, 90% effective, $90, make 90 phone calls, which is creating that brain pathway around asking for help. And you're going to have a part that's going to feel very forced. And so that's why IFS has really kind of brought a different way for us to work with our clients. Substance using parts in relational trauma, commonly seeking protection, escape, and relief when the internal system lacks safety and love. So that's what these parts are doing. They're going to use substances like food, drugs, sex, technology, and gambling as ways to cope. Those are their coping mechanisms. So multiple parts and dimensions are often involved. And they're not kidding, because we talk about complex trauma. The more complex the trauma is, the more the layers are of the parts, and more parts and parts, and they're protector parts, and they're going to be polarized parts, and they're just going to be, it's a parts fest, I think it says somewhere in one of these slides. And so that's what we need to think about when we're looking, starting to work with our clients. Like, where are we going to start? Which of course our client will be able to help us with. Substance using parts protect original wounds and secondary wounds that are tied to the substance consequences. So not only do you have the trauma, and then you have the part that's coming in that's using the substance to protect the client from the wound, but then you have the consequences of the actual use. My adolescents call it treatment trauma when they have to go into treatment because of their use, and then they're traumatized by their treatment. I thought that was clever. And then, what is the role of internal family systems here? It really opens things up. It really gives us an amazing opportunity to work with our client in a different way. There's an excellent workbook out. I don't seem to have it in my mess of workbooks, but it's working specifically with IFS and addiction, and talking about how those parts interact and the polarities. So understanding the protective intention of the substance using part, not to force change, right? Healing involves addressing that original wound and then looking at the present day secondary challenges. Those challenges are going to be really, really strong protector parts. Oh, this is the video that got me in trouble, and I'm already in trouble. It's already got me locked. Okay, well, since we're going to be in trouble anyway, let's watch it.
None of us are unitary personalities. It's the nature of the mind to have lots of different, what I call parts, and that those parts are all valuable. An example would be something happens in my life, it triggers this critic who's brutal and makes me feel horrible. And that brings up a part that feels young and empty and alone and worthless. And that feeling is so distressing that then this binge comes in to get me away from it. The binge triggers the critic again, who's calling me a pig on top of the other names. These aren't just little voices or thought patterns or emotions. Those are the manifestations of these parts. If I were to have you focus on one of them, you'd find out that it's a full-range personality that really has a lot to tell you besides the little thought it's giving you. Mm-hmm. And that it's stuck in an extreme role because of something that happened in your childhood maybe. And through trial and error over time, we found out how to help all these parts change and become who they're designed to be.
And that's really powerful until I can't get out of it, which is the problem that I had before. So I need to stop share. Sorry. And so I think that that's really interesting that we can look at these parts from a perspective of, we have all of these individual parts that we're going to be working with from a therapeutic perspective, that when we talk about unconditional positive regard, and we think about reflective listening, and we think about mirroring, all of those things that we learned as therapists, that we're going to be utilizing these skills with all of these different aspects of the client. And so now give me a minute. Eric, do you have anything to say while I have to redo this real quick?
No, I'm going to look for that. I'm finding a different version than that video, but it's that I'll put out in the chat. But Again, I would just probably say, Paula and I commented earlier, when we get into working with these kinds of parts, this is amongst the most difficult aspect of what I find in the parts work that I do with people, because there's so many opportunities for critical aspects of self, managerial aspects of self that implement as protectors, and then very young protected child parts. So that's what I would add to what you're saying. And we're seeing, there you are on,
right.
there is a thing on the upper left-hand side.
Okay.
Oh, good.
Is it good? Is that good? All right. Eric, can you hear me?
Yeah, that's good.
Okay, thanks. Sorry, we're having so many problems this morning. It's just kind of the aura around here. Anyway, all right. So substance using parts, we've got drinking, eating, smoking. This comes directly from Frank's book. The primary wound, which is going to be the past wounds. It's going to be the exile, let's just say, for example, or maybe it's a protector part. We've got a secondary, and then we're going to have another secondary. So at the end of the day, they're going to be layers and layers and layers. He's using feeling alone and unlovable, being in an unhappy marriage, losing friends as a result of drinking. The feeling alone and unlovable can be coming from a very, very early time in life through an attachment rupture, moving into an unhappy marriage. We all know how those patterns play out. If our clients don't seek help, they end up going in and repeating some of the environments that they're in. And then once again, the consequences of the actual using. So just looking at the layers here. Wow, am I having trouble? I'm so sorry. Okay, so following the client's internal wisdom for the sequence of healing. So we want to be thinking about these parts, but we always also want to be thinking about how they're polarized. And when you've got a polarized part, you've got a part that wants to do something and a part that also wants to do the same thing, but for different reasons. So just an example, if I keep eating, I'll feel unloved and worthless, just like when I was a child, because my parents were so critical of everything that I ate and always told me that I would be fat and lonely and nobody would love me. And then if I keep eating, I won't be able to suppress my urges or will feel miserable. So looking at the same idea, but looking at it from two different perspectives. That's exactly what our polarized parts do. So also polyvagal. Polyvagal is important because we're looking at not only our parts, but we have to look at what kind of polyvagal energy our parts are holding, because that makes a really big difference. We're starting to talk about what's called the orange state because of some of the things that are going on in our world right now, where you can be hyper aroused and hypo aroused at the same time. But in this particular example, thinking of being hyper aroused, seeking sugar or satisfaction through food, for example, and then hypo aroused, restricts and suppresses guilt post consequences. So in other words, what is that shutdown look like when you've gone through and activated what it is that you've wanted, and then there's this other part that's going to come in and most likely shame you or shut you down into a hypo aroused state, and how we're going to be going back and forth between the two. And what does that look like? So in working with addiction and trauma using internal family systems, it's important to differentiate between these parts, habits, and the biological dependence. When we're looking at addiction, we've got this complicated piece because we also have the habitual piece. The habitual piece is going to be revolved around patterns and triggers, and it's not necessarily like other protector parts. It's a habit. Biological pieces, we've got a lot of stuff going on with the brain chemistry and the brain structures. And it's important to understand it. And it's hard when you're using words like, glutamate and GABA and endorphins and what am I missing here? It's the structures like the prefrontal cortex, the amygdala, different aspects of the prefrontal cortex. It's all an aspect of what's going on for our clients. And so we really need to know the neurobiology behind the parts work as well, which Frank, he's brilliant. So he really spends a lot of time on that, as you saw in chapter 10. So substance using parts may protect one or multiple wounds, while habits and the biology often involve distinct challenges. So once again, the habits and biology are going to be separate from the parts. And then the effective healing requires addressing these underlying emotional wounds. So eventually we need to get to the exiles, which we all know that's hard enough. And then we also need to identify the habitual behaviors, because the habitual behaviors are not the protector parts. And then we need to take into consider the biological effects, because you've got this brain chemistry, you've got these neurotransmitters that are literally creating, like, for example, dopamine is all about, there's a book called Dopamine Nation. Basically, everything's about dopamine. And dopamine is that aspect, that neurotransmitter that is actually, it's a hormone also, I learned, but it's about motivation, and it's about when a client experiences something positive, it's going to seek that to happen over and over and over again. And so that's also an important aspect of what we're working with. Our clients are going through a lot. The protective parts and wounds, not all addicted parts protect the same wounds. And that makes it even more complicated. One part may protect multiple wounds, while different parts may protect various exiles. Protector parts often maintain behaviors until they are informed until they're informed of unburdening or alternative solutions. This is one of the many, but one of the many aspects of IFS that has really helped me in the work that I've done. Like I said, I totally admit this is new for me in the last couple of years. The unburdening, the being able to inform the client that the client can be unburdened, the unburdening, the giving back of shame, the redo. We have so many options once we get to those exiles, which are hard to get to. And there's language for this. This is what I really appreciate about what Dick Schwartz does, and that what Dr. Frank Anderson does. They give us language around what the game plan is. What's our ultimate goal? What's our end game? And our end game is to get to the exiles, and our end game is to unburden and to give the shame back to those that it belongs to, and to engage in redos if that's something that's going to help our client. So there's a lot of hope there, and that's all internal. This external environment stuff that's going on, we can really help our clients work on what's going on internally in our offices, and the relationships and how they manage and monitor their external world. Habits, once again, different. Repetitive behaviors often tied to routines and specific triggers. So we look at them differently than, let's say, a protector part. And then the biology. The biology is going to be the neurotransmitters and the dependence that comes from withdrawal symptoms, tolerance, urges, and how the body and the brain is adapting to the substances that are being put in, or the substances that are being used. To take into consideration that if you have a client that was neglected and they had opiates being released into their system from a very early age, because that's what happens when you go into a hypoaroused state. And then all of a sudden, here you are being, given painkillers at the age of 16 because you have to have surgery on your knee. And then the next thing you know, 1 in 10 of those get addicted. So it's, I think 85% of women that are addicted to heroin, it started as a prescription with a doctor. So I'm not even going to go there. That's not part of Frank's book. So addiction, compulsive use of a substance despite harmful consequences, often tied to the protective parts. We've always known that addiction, that the client consequences, if they hit rock bottom, that might be what it is that assists the client to get out of the place that they're in. But this is a different approach, because it's like, we don't have to hit rock bottom. We just need to start working with the parts that are protecting the client. And then around dependence, knowing that the dependence has something to do with what's going on with our brain chemistry, and that it's not something that a client can control. It's not something that a client can turn off, that their prefrontal cortex is not accessible, that impulse control is not something the client has, and that this is happening. This is not something that we're choosing. This is something that is part of the shifts in the biology when we start getting ourselves addicted to something, which maybe we've always been addicted to. We've just transitioned from what's internal to external. And then address the underlying wounds first, followed by the behaviors and the biological dependence. We don't always have that as an option, but I understand what Frank is saying. You know, if we can get to the wounds, then the need for the use will start to dissipate. But habits may persist even after unburdening. And so it needs to be explored separately. One of the things I learned about, not for you to remember, but, you know, I'm trying to understand the different neurobiological neurotransmitters, because that's where all the answers are. And their glutamate is the one that I was focusing on recently. And glutamate is basically what memorizes a client's a brain pathway around addiction, and it never goes away. So, you know, you can have a client that's been sober for 30 years and they can be triggered by something and go right back into addiction. Oh my God, it breaks my heart. I'm so upset about Justin Bieber right now. Can't even stand it. So anyway, so thinking about it from a biological perspective, thinking about it from the fact that we have these habits that are triggered, and then, of course, we have the ability to work with the parts, which are going to be very separate from all of this. Examining the wounds underlining the substance use. Once again, he's repeating himself here, but I get his point. Address the habits, the rituals, and the routines. Plan for safe reduction of substance use. We do have to take that into consideration. If you're working with benzos, it's a very dangerous withdrawal. If you're working with alcohol, it can be a dangerous withdrawal. For opiates, it's not a dangerous withdrawal, but it's a horrible one. So, you know, taking that into consideration. And then trusting the client's system to prioritize the sequence of healing. Sometimes our justice system doesn't allow that to happen. Sometimes there are so many consequences. And, you know, trusting the client's system around motivation. If you're going to lose your family, if you're going to lose your job, then hopefully that will be where the client will prioritize the sequence of healing. And then addressing all facets of our addiction, where we're looking at parts, we're looking at the habits, and we're looking at the biology, and we're looking at this separately, right? Parts is the answer to everything for a lot of the populations that we work with, but it's not here because we literally need to look at the biology and the habits differently. So this is once again pulled from Frank's book, looking at the difference between the three, looking at the parts aspect, how many parts are using the substance, what are their jobs, how many wounds are being protected, are they from the past or the present, right? Going at it from a habitual perspective, you know, what is the behavior? Is it a part or is it a habit? How best to address it? Do all parts agree? What's the order? So we've got a habit that isn't a part, but you've got parts that use the habit, just to make things a little bit more complicated. And then we have the biology, and this is going to be where dependence is. And if you look at a continuum of addiction, dependence is going to be the last category, because dependence is where you absolutely need help, because now the brain is taken over. Now the neurobiology is taken over. So you can do all the parts work you want, but at the end of the day, when a client is in dependence, and hi, Roxana, I see you here. Roxana and Eric, if you could go into my resource page under addiction and pull that continuum. I love that chart, and it basically shows you how we get to dependence. And dependence is the biological effects of the substances. How best to taper or withdrawal? Do all parts agree? What's the order? Because we're talking about neurobiology here now, which is going to be very different than just working with parts that are protecting. So when addressing substance using parts, it's common for a cluster of related parts to become activated, making it more challenging to access the underlying wound. For those of you that have been trained in meeting place or conference room technique from Dr. George Fraser, this is a beautiful opportunity to start meeting with the different parts that are affected, because it's going to be more than one. These current parts, they're going to be critical parts. There's going to be caretaking part. There's going to be intellectualizing parts. These parts often have protective intentions, but they can complicate the healing because we also have shaming. We have the parts that want to come in and fix, and then we have the parts that overanalyze everything, because that's really protective as well. Working with these parts requires persistence, patience, and compassion to gain their trust and create the space necessary to engage with the wound. So when you think about, let's say, for example, meeting place, and you have a conference room table, I'm just thinking of my own, for example, and you have different parts there, it's like having a family and doing a family session. We need to get everybody on the same page. We need everybody to, all the parts to respect each other and understand each other's perspectives. You don't have to agree, but you need to agree to disagree in order to come to some type of compromise around what the healing's going to look like. Critical parts shame the addictive part for its behavior and the trouble it has caused internally and externally. And then you have caretaking parts that try to please, fix, and guide to prevent the system from experiencing pain. And then you have the intellectualizing parts that overanalyze and hold on to the story to maintain control, often blending with the system. So there's challenges here because then at the end of the day, we want to get to what's underneath it all, which is going to be the wounded part. The groupings of these parts make it difficult. Once again, why I think a meeting place or conference room is kind of a beautiful place to do this work. These parts are often persistent and resistant to creating space for healing. So once again, if you're trained in meeting place, it's a really nice script that gets the clients parts. They get to figure out what a meeting place looks like. We want everybody to agree with how we create this safe, secure space so that we don't get the resistance. Permission, validation, welcoming, accepting, appreciating, acknowledging, and building trust is the key to working with any part that you come across. So at the end of the day, that's going to be the starting point. Let's see here. I think that covers, at least that covers his chapter on substance use. I thought it was pretty intense as far as looking at it from the parts perspective. Is there any feedback, or can you put a comment or two? If you read it, if you didn't read it, it doesn't matter. Just the conversation that we're having today. It's just a brief overview. There's a whole workbook on this, but any comments working with this population and looking at it from an IFS perspective?
There isn't anything coming up right now in the comments. I'm going to put out a link to the introductory video that is done for the meeting place related information by Dr. George Frazier. Really interesting, though. Just a comment. Curious about parts work, how that would come into the rooms. Would you mind?
Yeah.
Yeah.
More so than ever now. I just the parts work is now something that we just have to jump right into. And it's not about sitting down with your client and saying, oh, we're going to talk about firefighters and managers, et cetera, et cetera. It's a part of you is experiencing this. A part of me is experiencing this. It sounds like there's a part of you that's really upset about this. And then there's a part of you that's really shut down. The parts that are walking into our room, we just need to jump right in. And one of my struggles that I'm experiencing right now, and literally could bring me to tears, is I am having a really hard time unblending from what's happening in our world and being in self, whatever, with my clients. because my clients are activating me right now, and I need to work with my parts separately in order to work with my clients. And it's everywhere. So the short answer for Dr. Frank Anderson is you just jump in and you say, what I'm hearing you say is there's an aspect of you that had a really crappy weekend this weekend because of X, Y, and Z. And then I also hear that there's a part of you that went to a concert. And so that sounds awesome. Tell me about it. What was that like for you? And really engaging with all of the different parts that are coming into your sessions that are right there in front of you, without having to say, and we're going to do parts work today. Just do it. Just jump in and do it, because it's just, our rooms are crowded. And not only are they crowded with our clients' parts, but they're crowded with our parts as well. So I hope that helps. There's no explanation needed.
There was a really nice comment. I might out you inadvertently, but what about when your clients are triggered by parts language?
Then don't use it. Use the word aspect, use the word energy. I feel an energy that's really angry right now. Can you know, because when we're working with parts, the first thing we want to do is direct access. And the goal is to unblend the part, but the direct access, if you use implicit direct access, it's just working with your client. So if your client's angry in that moment, your goal is to just work with it. You don't have to say anything. That's why they call it implicit. And you can just work with it. Wow, I feel like you're really angry right now. I can pick up on the energy, what's coming up for you. You know, remember, we want to validate with our acronym HUGS. I hear you. I understand you. I get you. I see you. And that's easy for us to do right now. Like, I hear what you're saying. I understand what you're saying. I get what you're saying. I see what you're saying. We can invite our client to unblend. We can either tell them, well, we're not going to tell them because we're doing this without bringing the words parts in. But the unblending is there any way that we could take this energy, this angry aspect of you, and just put it in like a chair here, so that it's your angry energy, and it's you? Because can you understand why this aspect, this energy is so upset? Like, you don't have to use the word parts, but it's there. We can feel it. It's palpable. So let's figure out what language will work for your clients, because they know it. It's, if you want to take it into a polyvagal, if you do polyvagal with your client, all you have to say is, I'm feeling some yellow energy right now, like sympathetic, you know, we call it yellow. My clients are always talking about if they're in red or if they're in yellow. And now we're talking about orange. And then if they're in green. So find the language that works for you and your clients. At the end of the day, the neurobiology is all the same. If you use parts language, polyvagal language, it doesn't matter. Does that help? I hope.
Yep.
Okay. Should we move to our next chapter?
Here we go.
It's another one.
Now, by the way, this shifts sections in the book, so we're moving into a separate section in the book.
Yes. And it's another cheery one. Shame. IFS has just changed my life when it comes to shame. So let's move in. Okay. So shame cycles. Shame develops when there's vulnerability, and vulnerability is a relational rupture. It's when there's a severing of self-connection and a reinforcing of worthlessness. So when we talk about in internal family systems, this concept of higher self, whatever that is for you, we don't, it's Gabramonte's attachment versus authenticity. We're focused on attachment because we're focused on survival. And our authentic higher self is not a part of what happens when we're growing up, because that, like it says, it's severed and it is not respected. It's not honored. It's not encouraged. And at the end of the day, we need to figure out how we're going to survive. So we survive through aligning with whoever our primary caregiver is. Its act as it acts as the opposite of love and connection, disrupting identity and relationships. Once again, I'm going to pull in that word authenticity just because Gabramonte does such a beautiful job. And if you guys want to throw that video in, it's only 3.5 minutes and it pretty much sums up the whole concept of shame. I know he never uses the word, which I find interesting. Internalized beliefs like I'm bad, I'm wrong, I must have been the problem emerge. And we know where that comes from. It comes from the attachment ruptures. It comes from the developmental trauma. It comes from the lack of safety. It comes from our primary caregivers, given whatever attachment we're experiencing. The client once said, when shame dominates, trauma, or a client once said to Frank, when shame dominates, trauma wins. It blocks the love I have for myself and others. IFS talks about how we can literally take the shame and give it back. I love that. I freaking love that. I never thought of shame that way. Yeah. I don't know if anybody recognizes this picture, but it's from Korea. And all of those are the locks of love. Not sure if you're up to date on that, but anyway, it's a special picture. I get to do what I want, right? One shame cycle stems from critical or verbally abusive caregivers who react from a hyper aroused sympathetic state. So hyper aroused, I put up our trauma traffic light here. It's yellow. It's our fight flight. And so the shame cycle is going to be initiated by this abuse. And then another type of shame can come from neglect or emotionally abandoned caregivers who respond from a hypo-aroused parasympathetic state. So one of the things that we said is, what kind of energy are these parts holding? Is it a hyper-aroused or a hypo-aroused? Is it red or is it yellow? Because that makes a big difference on how we work with it. And once again, what we learned from Frank's book in the last month, the last chapter, is that we work with the hypo-aroused dissociative states by being with it and sitting with it and getting to know it. So when your client has a wall or your client has fog or your client has a cloud or your client has some type of emptiness, we don't shift them into and move them into a different state. I mean, you do it with other orientations, and that's great. But with this orientation, you get to know it. I'm blown away by it, really. The work is just so powerful. Critical caregivers use flight mode energy, reinforcing shame through harshness and rejection. And neglected caregivers function through a withdrawal or collapse. So you're basically explaining what attachment style is being used here with the language from Polybagel, which is powerful. The origin of shame. Verbal abuse or harsh criticism create an exiled part that internalizes messages of being worthless, bad, or unlovable. So from looking at EMDR, if you're EMDR trained, we're looking for those exile messages, which is I am unlovable, I am unimportant, I am defective, I am worthless, I am not good enough, et cetera, et cetera, et cetera. That's what we're looking for, is that exiled part. And then we've got the critical part. The critical internal part can develop by adopting the abusive energy or as a legacy burden carried into the client system. If dad yells at you all the time, you learn to yell. And if you learn to yell, that's considered a legacy burden because it was given to you by dad. And then if dad shamed you with that yelling by saying that you're a worthless piece of crap, now we have shame that we can give back to dad. We can release our legacy burden and with a ceremony, and then you can give the shame back to dad. This is the work that we get to do with our exiled parts when we find them, which is really difficult to do. So that's, I don't want to make this sound impossible because it's not. There's good news, and I hope that I remember to tell you what it is by the end of this. But its protective strategy is to criticize other parts to prevent further shame and rejection. So once again, I talk about this when we talk about psychoeducation in our basic EMDR training, talking about why am I blanking on it? Not cognitive interweaves, but clinical interventions when we're giving psychoeducation to our clients around if your parent, if your primary caregiver was somebody who abused you in some way, shape, or form, you need to have a part of you that can align with that abuse so that you can trace every single move, every single thought, everything that that perpetrator of or abuser is going to do to keep you safe, which means you have a part that is identical. And that part does come out. That and then there's shame because, oh my God, I yelled at my own kids the way that I was yelled at by my dad. I'm such a horrible parent. How could I do that when I swore I was never going to yell at my kids? Well, that part came from protecting you and so you could survive as a child. So, and you probably used it when you went to school with kids as a way to feel empowered because you felt so powerless when you were home. Okay, I'm getting way off track here. So, protective parts, pleasing and perfectionistic parts that seek approval to avoid criticism. These disconnecting parts may dissociate or leave when distress becomes too overwhelming. So, we've got to think about what polyvagal energy our clients have. So each protective behavior can trigger more shame. So you can have substance use that causes guilt and regret, substance using parts that then come in and soothe the emotional pain, failed attempts to please or be perfect, which lead to self-blame. Disconnecting can hurt loved ones, reinforcing shame over abandonment. It comes from all over the place. And all of these can be worked with from a different perspective in that we can work with them as parts. The compounding effects, when protective parts realize they're mirroring the same abusive tactics they endured, then you've got more shame. So once again, if you are there yelling at your children and you were yelled at as a kid, there's so much shame. And this comes from, this also is not just about like something, for example, hyper arousal, where you are looking at energy, a fight flight energy, but hypo as well. So, I mean, if we're going to start talking about sexual abuse, which Frank really doesn't touch on, curious, but the sexual abuse is a whole other another piece of teaching that could be really helpful here when it comes to shame and just how that plays out when you're abused as a young child and what that looks like as an adult. Pointing out these dynamics can inadvertently add shame. So talking about them isn't going to be helpful. The psychoeducation can be helpful so that all the parts here, but not working with the part one-on-one until the part is ready. And of course, we would use, compassion when doing that. The therapeutic goal is to offer a non-judgmental space for these parts to be understood. So, okay, I am going to bring one aspect of sexual abuse in here. If you have a client that's sitting in front of you that says that they are concerned because they feel like they're maybe getting aroused when seeing, a certain age, maybe, like working in preschool, for example, and that they're really concerned because there's some sexual arousal there. Is that something that you're going to sit with and you're going to be able to validate and you're going to be able to welcome and you're going to be able to accept, appreciate, acknowledge, and build trust with that part? I mean, that's something you need to ask yourself if you're going to be working with clients that have experienced that type of abuse, because it doesn't matter what the client experienced. And this is where Dick Schwartz comes from, because he did work with, I'm not going to go into the details, but it's just a really important question to ask ourselves. How are our parts getting activated by what it is that our clients are bringing to the table? Shame is rooted in the fear of disconnection. So you can imagine what kind of attachment you come from, what that fear must look like, and the belief that one is fundamentally flawed. This resonates with the experience of the exiles in an IFS framework who feel they do not deserve love or belonging. And I just put this on here. I think there's a video that I play in one of my trainings where the exile is exiled to the top of the castle and you can't get to it because it's just got layers and layers and layers of protectors, including a moat around it that's not going to let anybody in there. And so once again, that kind of looks like what we're going to be working with. And these particular connections come from Brene Brown. Frank does a nice section on referencing her work. Shame is a primary wound caused by relational attacks on vulnerability. Healing involves recognizing how each part functions and gently releases the burdens that keep them stuck in shame. So at the end of the day, that's what we're going to be doing. We want to get to those exiles. We want to release those burdens. We want to give back the shame. We want to do whatever it takes in order to heal that exile. That is our ultimate end game. That is our goal. Personalized neglect. Children often blame themselves for a caregiver's disinterest, leading to feelings of worthlessness and shame. Okay, so if you've got a caregiver that is repeating these behaviors over and over and over again, and it's not about blaming the caregiver, I'm sure they experience that this is generational. But at the end of the day, we do need to find where the accountability goes so that we can give it back, which is cool. Ken, I don't want to butcher his name, Benau, he's amazing with shame. So if I mispronounce his name, I'm sorry. Ken B. Not receiving love when vulnerable is inherently shaming. If you're looking for somebody, if you really are interested in shame, I would definitely look at some of his writings, and you can even look at some interviews. You don't have to purchase anything. And then Bessel van der Kolk, fear of betrayal and abandonment can overshadow any desire for closeness. So very powerful statements about shame. And then when a caregiver is withdrawn and emotionally unavailable, the child may learn to disconnect as a means of protection. Once again, this is a relational injury, which leads to shame. Protective parts do then emerge. You can have a numb or disconnected part, which would be a red hypoarousal. You can have an intellectual part that fills the void and overthinks and blocks painful emotions. That can be a yellow, sympathetic, because it's a mobilized action. We talked a lot about this in the polyvagal book club or book. What are these called? Book reviews. Polyvagal World with Stephen and Seth Porges, talking about the different parts and talking about their different energy and what that looks like. Out of here parts conclude that love is impossible and detached completely. And so you're going to be yellow energy and red energy, an orange energy, where you're going to push people away and then you're going to shut down. Protective strategies aim to avoid further hurt, but often reinforce the exile's sense of being unlovable. I saw a documentary on Apple's a long time ago. It was about a woman who had children and she was diagnosed with DID, dissociative identity disorder. And I'll never forget how powerful it was when the interviewer said, do you think that you'll ever, get into another intimate relationship? And this was such a powerful answer. She said, no. She said, I will never, ever put my child parts through that again. I mean, that just brings tears to my eyes. Now, Frank talks about this. He doesn't talk about that particular documentary, but at the end of the day, what he talks about is how our clients, once they are able to heal, that they're like, I'm never freaking doing that again. And they create this like really safe space for themselves. But at the end of the day, the reason why we want to heal the exiles and remove the shame and give it back to where they belong is so the clients can go out and reconnect, which is something that they really don't want to do. So having never learned genuine connection, these children turned adults struggle to recognize and accept love, which is perpetuating the isolation. Over-resilience on intellectualization and perfectionism can push other ways, worsening the cycle of loneliness. We all know what that looks like, especially being therapists that are trying to learn as much as we can and be as perfect as we can. Healing requires gently addressing each protective part, validating its role, and helping the client learn to safely connect and receive care. So it doesn't matter what the part does. This is our job. Shame is central to many trauma wounds, causing feelings of isolation, worthlessness, and disconnection. At the end of the day, shame is disconnection. It is a relational wound. Although most visible in critical and neglectful caregiving, shame can also stem from bullying and other relational betrayals. When we think of Erickson's developmental phases and we think about, we've got, let's see here, where's control? Hold on. When we go into that 3-year-old to 5-year-old, and then that 5-year-old to 12-year-old, we're talking about relationships. We're talking about responsibility. We're talking about how our external environment really starts to affect how we feel about ourselves. It starts really early, and especially with social media, we've got some real messes out there as far as some of our children and what their self-worth looks like. Parents are doing the best that they can, but it's kind of a mess. To cope with shame, individuals develop strategies like becoming bullies themselves, seeking perfection, or numbing out, which can perpetuate the cycle. And then that just takes us all back into our addiction chapter, because at the end of the day, when you're in a hypo-aroused state, you do have endorphins that activate the opiate receptors. Opiates are painkillers. Opiates are heroin. they are basically already being released into a client's bloodstream before the client even takes something externally that would have an opiate in it. When caregivers operate from a hypo-aroused shutdown state, emotions, including shame, become harder to access and process. So true. But learning to sit with and be with those dissociative parts, very powerful. Some parents show both harsh, verbally abusive behaviors and neglectful withdrawal, creating especially toxic conditions for shame to thrive. We're really starting to focus on this orange state, and that's exactly what we're talking about. We're talking about a combination of both showing up literally at the same time. And if you think about cortisol and adrenaline being released when you're in your sympathetic state, and you think about endorphins activating your opiates when you are in a hypo-aroused state, not to mention GABA, which we're not going to talk about, you have a kind of a, I want to swear. Can I swear? A shit show, basically, internally. So it's just the feelings that are going on, what the client's experiencing can be really confusing. Therapists must gently explore these internal cycles without reinforcing shame, allowing protective parts to unburden and exiled parts to heal. So if you don't know what unburdening is, and if you don't know, how to get to an exile and release the shame and release the unburden, whatever is brought on by maybe legacies, don't worry about it, because by the time you get there, you will have learned. Right now, it's literally about working with these protector parts. So the neurobiology of shame, we've got the dorsolateral prefrontal cortex, and it's just like, I only know about the prefrontal cortex. I'm learning that there's different aspects of the prefrontal cortex, but the part of the prefrontal cortex that we're struggling with here is the logical decision-making and the prefrontal cortex that works with impulse control. So there's another aspect of it. I'm not going to speak to it because I can't, but basically, this Frank talks about it here. Transitioning from mild sympathetic activation to parasympathetic shutdown. We can put language to that, going from yellow to red. Once again, polyvagal and internal family systems, we really need to integrate the two. It is so essential. Creating many traumas that are at the root of many relational wounds. So this isn't just playing out from childhood, but it plays out into our everyday experiences, especially now when people are so on edge. Elicits feeling of physical discomfort similar to actual pain, prompts withdrawal and social isolation, and undermines a person's sense of safety and connection. So we're talking about shame here, but we are also talking about fear. And at the end of the day, fear is where all protector parts come from. And so if we look at fear as the foundation, and everything that comes out of the fear, including shame. Once again, just talking about, our external environment right now, there's a lot of fear. And so there are a lot of protector parts that are activated. And so we need to think about like how we're going to be working with those. So internal family systems and parts views the mind as made of subpersonalities. So like Dick said very quickly in his 1 minute video, in that we have these different little personalities that we're going to be working with, and that we want to treat each one of them separately with respect. We want to validate them, and we want to build trust with them. And so that's recognizing, accepting, and integrating both positive and negatively concealed parts. I love to use lying as an example. I get a lot of therapists that come, I do a lot of consultation. Therapists say, my client's lying to me. I know my client's lying to me. And that's a part. That's a part. If lying saved them when they were a kid, they're going to continue to lie. So you need to validate that lying part. You need to build trust with that lying part. You need to accept, acknowledge, appreciate, and welcome that lying part. So don't worry about it, because at the end of the day, you need to just build a relationship with. Encouraging self-compassion as the foundation of a healthier internal and external relationships. This is a lot harder than it sounds. There was research that was done, not to get into the detail, I kind of skipped over that, but there were 3 training modules that were studied: presence, affect, and perspective. Perspective module, which is the module that comes after IFS, shows the strongest improvement in the theory of mind and social cognition. So at the end of the day, just looking at internal family systems and some of the research that was done and why it was chosen. So you can go back to that chapter, part of the chapter, if you want to read more about that. And then greater self-awareness correlates with enhanced empathy. Frank does there's so many references about how he ended up doing his own work. And it's really starting to hit home with me, because at the end of the day, it's about our parts and what parts of us are getting activated, and really being able to embrace that. And that's a tough thing to do. Like I said, especially in this environment that we're in. Just looking at time. Relevance to a complex world. Self-acceptance fosters tolerance and compassion for others. So self-acceptance, how are our clients going to learn to accept themselves? Because we're going to mentor that for them. We are going to mentor that with hugs, with our, I hear you, I understand you, I get you, I see you. Skills in perspective taking are increasingly vital for bridging cultures, cultural, religious, and social divides. So once again, that's going to come from us originally, and we are going to mentor it. And then we want to, in an eloquent way, hand it over to our clients. We don't want our clients to rely on us too much for this. We want to mentor it and teach it to our clients, and then share it with them so that they can engage with their parts in this way. IFS-based approaches can be powerful tools for individual growth and collective harmony. Yeah, like, okay. Okay, any thoughts on the shame section? I've never, ever done anything in my teaching on shame. In fact, I always tell my groups, I don't know, let's see, I'm going to have 16 consultees right after this. And I can count on 2 hands, and I've been doing this for many years, how many times shame is brought up as a theme. Because I always ask my groups, what are our themes today? What is it that you want to hear me integrate into EMDR? And dissociation is the most popular. Polyvagal is a good one. How to work with addiction, working with children, working from a school setting, working with hospice. Nobody ever asks for anything about shame. It's amazing to me. So I don't know. I hope that maybe
Paula,
gets you thinking about it.
There was a really good comment. My gentle answer is, when we're thinking about bipolar, borderline personality issues, that we probably really can't have a full discussion in terms of IFS until we get through the polarity section on, with respect to with respect to BPD. Now, again, there's
I didn't bring up both. I didn't even mention borderline, right?
yeah, but again,
Okay,
there's such a deep sense of shame when I'm working with the borderlines that I've worked with.
sure. And
But
that's
it's
coming
such
in the next chapter. Yeah.
exactly, it's a hugely polarized piece of
Hmm.
what a client is dealing with. So that's kind of how I sort of, you know, uh,
Yeah.
thought of it. But I just wanted to mention that because it is a big deal and it is so much shame generated as well.
Hmm.
Um, there's loads of theories about the emergence of borderline, but I
Hmm.
think polarities is part of the way.
It definitely is. In fact, that's what's in this chapter. It's interesting you bring that up. We go from substance use directly into shame, and now we move into polarities because that is the name of the game. So, yeah, good. Anything else? Roxana, anything coming for you? Do you have any thoughts?
No, I put up the slide that I had screenshot for hugs that you beautifully
Ah,
shared with us, and what because it's just so beautiful. I've been using it even more and more and more, and it's just been very helpful with parts work.
mhm.
Very
It's
helpful.
how we start the development of self with the client is to mentor that. So, once again, going back to that question about how do we start parts with our client, you're just going to work with the client that is going to be in the part is blended, and we're not even going to think about unblending it until we've validated that part so much that then the client can start to validate its own part. That's the first thing that we do. And we don't even have to talk about anything else when it comes to IFS as far as the next step until we've been able to get the client to be able to say, you know what, I totally understand why I'm so angry. That is the unblending right there. And the reason why the client can say that they understand why they're so angry is because you just shared with them over and over again. I so understand why you're so angry. Oh my gosh, I so hear what you're saying. I so get it. Yeah, like, wow. And then, like I said, that's where the client learns it. And then you gently hand it to the client where the client can say, I get why I'm angry. There, you just unblended and you just created self. Good job. Okay, let's move into chapter 18. Whew. All right. These some intense chapters. Anyway, all of Frank's stuff's intense. All right, multiplicity of parts. So here we're moving into exactly what Eric was referring to. We've got systems, we've got severe trauma and polarities. Polarities is the name of the game, especially moving into 2025. Systems often include extreme protectors. We're talking about suicidal parts, substance using parts, and they're strong managers, plus hidden exiles. You're like, so at the end of the day, all of our parts are protectors. They come out of fear, let's just say. And then our protector parts are going to be our managers and our firefighters. Frank does not call them firefighters. He calls them extreme protectors. So at first I was like, firefighter, oh my gosh, like firefighters are these, guys that come in and they're helpful. I should say guys and gals. I've got two down the street that are gals. And why would we call them firefighters? Because they kind of get a bad rap. Well, when I had a fire, I figured it out. I was just telling the story the other day. Hope nobody has to hear it again. When I had a fire on Christmas Eve one year, the firefighters came in and they tore the place up. They had their hoses, they had their axes, and they put holes in the walls, and they destroyed everything to get to the fire. It was in a really strange place between the fireplace box and the wall. So there's this fire there, and they tore up the deck on the outside, the wall on the outside, the wall on the inside, and then they took their hose. The amount of damage that was done was freaking amazing to get this very small fire. My point is that firefighters do what they have to do to put the fire out. They don't care about anything else. So I get it. Right, Susan? I get it. I'm like, oh, this makes so much sense. So now when I think of firefighters, I'm like, okay, I get it, but I don't want to have to explain all that. So Extreme protectors is Frank's language. And yes, a firefighter would be an extreme protector. You come in and you get the fire and you don't give a crap about what the results might be as far as everything else goes. So, and then we have our managers, and our managers are going to be the parts that are like, oh, no, 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 we shouldn't do that. They're always concerned about the future. They're always trying to make sure everything's going to be okay. And so you can imagine that when you have these extreme protector parts, you're going to have managers that are going to be on them. Like, what do they say? Like white on rice. And then we have our exiles that are going to hold traumas. They probably hold lots of trauma over time. And they're going to be multiple exiles that may each carry specific events. Now, I just want to say with the exiles, we don't need to worry about that yet. There are trainings on working with exiles, and getting to the exiles is, we call them exile hunters. Sometimes we EMDR therapists, especially because we're used to results, we go for those exiles, and we're looking for those exiles because we want to get in there and do the healing. But at the end of the day, it's really the protectors that we need to spend time with and build a relationship with, because once you start working with those protectors, and the ones that I'm talking about really are going to be the hypo aroused protectors, working with dissociation, not blowing through it, but working with it, honoring it, and having the dissociative part give you permission to go to the exile. Crazy powerful type of work I've never really engaged in myself. So an exile may hold several traumas. I think I just said that. And that these can form an intricate, interwoven system of wounding. So here we are with the dissociative complexity. Dissociative disorders often feature protectors that are slow to trust and resist revealing who and what they guard. So true. If you ever sat with a dissociative part, whew, wow, it's rough. The Practice EMDR is a great tool out there where you can go in and practice EMDR, but you can practice anything. You can practice your parts work. There's their avatars, and basically the avatars are programmed. There's no AI component. They're programmed to be clients, and they each have their different root causes, and so they're kind of like, you know, video games, if this is what you like to do with your free time. And there's one that's called Sophia, and she has a dissociative part that comes up right away, and you got to figure out how to get past it. And you've got to use your language that you learn from internal family systems. And you need to work with a dissociative part that doesn't want, and you're like, it's terrified of you. It does not like you as a therapist. It wants you to go away. And you have to figure out what kind of language. This is where sensory, why am I blanking on it? Anyway, this is where the bottom up comes from, where we need to really work with what's going on in the body in order to connect with this particular avatar. But at the end of the day, the therapy requires us to use an amazing amount of patience and time to work with these parts, but it's so worth it. Early stages, engage protectors with implicit direct access, gaining familiarity without directly calling them out. So once again, this implicit direct access is what we talked about, where you're just working with the client. The client's blended with the part. It is what we know as talk therapists. We're not using the language of parts. We're not talking about parts. You're just working with one that's right there in front of you. Later stages, gradually shifting to explicit direct access, learning each part's spheres and functions. And so this is where the hugs comes in, because as you are validating the part, it's creating this ability for you to move into an explicit direct access and the beginning of unblending. Protector parts often need many invitations to allow the self to connect with exiles. So many invitations, it takes patience and consistency is going to be the essential way to build trust. So once you kind of understand like the priority as far as what we're going to do first, when we talk about hugs, once again, once you've done that, you know what you need to do next, and you understand implicit direct access is not telling the client anything, just working with them. Explicit direct access is kind of like, hey, can you role play that angry part for me? I want you to be that angry part right now. And I want you to use I statements. And I want you to just tell me what's going on for you. And so the client is still implicit with you, but now you've shared with them that they're doing it. That's the explicit part. That's the only difference. You still are not unblended, but you've got the client now being the angry part. I am so angry. All the stuff I pulled up on my TikTok, like, oh my God, get rid of that app. And I'm so angry at this and I'm so angry at that. And what am I doing? I hear you. I understand you. I get you. I see you. And so we're doing this direct access, and now it's explicit because the client is being asked to be the angry part. And then you ask the client, can you understand why this part's so angry? And the client's, yes, of course I can. Absolutely. Bam, you just unblended. Beautiful. Internal family systems, Frank Anderson has done a beautiful job. I'm sure Dick Schwartz does too. I'm sure, I got my training in Canada. Everybody does a lovely job, but it's beautiful language and specific directions on how to do this with these parts that actually lead to healing. And if you want the neurobiology behind it all, go to chapter 10 and see if you can get yourself through it. So once again, I think I'm starting to feel better. I'm back. My part of me that's excited about this is back. One exile can carry multiple traumas. Multiple exiles may carry the same type of trauma, or various exiles might hold distinct but related experiences. So we don't know. Navigating and healing these complex systems demands patience, persistence, and a safe therapeutic environment. So once again, that's what we're going to provide for them through the hugs and then through our other work, which is welcoming, appreciating, acknowledging, accepting, and building trust. Risk of joining the client system. Therapists may be pulled into believing the client's hopeless and defeatist narrative. This indoctrination occurs when therapists part aligned with the client's despair. This is where I'm struggling right now. I can't separate my own experiences and feelings about what my clients are bringing into my sessions, and so I just really appreciated that statement. It's essential to remain anchored in the IFS framework and trust the healing potential of self-energy. So at the end of the day, I personally need to figure out how to stay in my self-energy, which I'm still trying to figure out, and not engage with what the client is bringing in the room, which is really difficult. Not sure what you guys are struggling with, but that's something I'm struggling with. Continually remind both yourself and the client that transformation is possible. And of course, we all know that, especially if you're an EMDR therapist. While empathically recognizing the client's pain, maintain enough distance to see the bigger picture. So don't get blended with the client. Avoid over-identifying with the client's part or carrying their burdens. Very difficult thing to do, at least I'm speaking for myself right now. Use supportive but firm language to counteract hopelessness. I know you feel incapable of love, but I believe it's possible for you. So I am representing the client's self. At the end of the day, I'm hoping that at some point they can represent it, but usually not when we have complex trauma. Offer an alternative viewpoint that clients can heal and unburden despite their doubts. I need to believe in my clients. I need to believe that they can heal. And I need to embrace the internal family systems higher self right now. And this is hard because I can't figure out how to like work with myself at this point. So anyway, watch for signs that your own unresolved issues, hello, Frank, yes, help me, I need you, or protective parts are getting activated. Take steps to unblend so that you can provide clarity and a sense of possibility for the client. So really engaging into those 8 C's and figuring out how to be in yourself and telling your own parts. I'll get to you later. I need you to sit off on the side and not participate in this session right now. This is about our clients, not about you. No offense. Emphasize the client's capacity to tap into self energy and the core resource for healing in IFS, and remind them that that with permission from protective parts, real change can happen. And that's easier said than done. When to join and when to step back. Sometimes sharing in the client's experience helps you understand their pain. And at other times, you must step outside their system to challenge limiting beliefs and suggest paths toward unburdening. Once again, just a really hard thing for therapists to be doing right now. Therapists' own trauma can lead to over-identification with the client's system, and awareness and self-care are vital to ensure you're providing the best therapeutic support. So once again, the awareness and the self-care that you're experiencing for yourself, and then really engaging and understanding how our own trauma is being activated, possibly by our clients. Text change here. Severe abuse histories. Ongoing sexual, physical, and verbal abuse leads to numerous extreme protective parts. And I'll read these in a minute because I'm looking at DID here. And then protectors that can dominate waking and sleeping hours, hindering self-access. So Frank's section on DID, I just have to put this out there. There's controversy. Dr. Jamie Marich, wonderful, fantastic, love her representation on multiplicity. And you know what? If you guys could find the interview with Dr. Jamie Marich and Dick Schwartz and put that in the chat, that would be great. It's an excellent interview. I recommend all of you listen to it, because this multiplicity versus IFS, it's not necessary. And I think Dr. Jamie Marich realized that because she did the interview with Dick Schwartz. We need to work together. And there's some issues. And so when Frank Anderson wrote his section on DID, Jamie attacked it. So if you can go online and you can find when she's holding Frank's book up, she literally reads some of the things that he says. And she says that, this is not in line with, our thinking on multiplicity, DID, et cetera, et cetera. I think that's all been cleared up, but I just had to put it out there. So what I'm reading here obviously comes from Frank's book. It obviously is how Frank is experiencing his own DID clients. I have to admit, a little of it was triggering for me as well. There's no perfection out there. So clients with DID have numerous parts, many of them extreme. This is his language. They highly evolve self-like parts. Multiple polarizations, like many polarizations. Parts that collude and form alliances, parts that hide, exaggerate, and are dishonest. Crisis-driven systems, parts that present symbolically. Rapid eye movements are common when these parts are accessed. Parts often hate the self, and self is marginally accessible. So there's a lot here that's suggesting that there are parts that are not necessarily working in favor of the client, which makes sense. I mean, we know that about parts, but that these parts really, their goal is to trick the therapist, that their goal is to manipulate the therapist. These clients had to use everything they possibly could to survive, because usually the research around DID clients is that their abuse is severe and that they had to use anything and everything in order to survive, including needing to control their entire environment, which would, yes, include the therapist. So when looking at working with differentiating genuine self with a highly dissociative client, I'm asking, is this feeling coming from your head or your heart? Looking for bodily relaxation and a softening presence. Lying, withholding, and secret keeping all serve survival. So if your client are doing some of these things, at the end of the day, what Frank is saying is these clients are doing this because it had to be done in order to survive. So it's not personal. It's aimed at shielding exiles and preventing re-traumatization. And then rapid crisis management can feel like endless, I think it's supposed to be chaos. And then parts may initially appear in symbolic or non-human forms like dragons, boulders, et cetera, et cetera. I'm going to stop here because I'm noticing the time, and I really want to do this section, the justice that it deserves. And so I'm going to restart because we've got a little bit of 18 left, 19 super short. I made an executive decision not to stay on schedule because I don't want to not honor like some of the importance of some of these sections because I glanced at it and broke these chapters out according to what I thought would work for our book study. So why don't we plan on meeting back in a month? And I am going to start with the DID section from the beginning. And we'll finish chapter 18, 19, and we'll just keep going. Are we okay with that?
I'm going to go ahead and stop the recording. Susan's got a great question.
Yes, Susan.